Hypertrophic cardiomyopathy, HCM, follows an autosomal dominant inheritance pattern with variable penetrance and expressivity, meaning affected individuals have a 50% chance of passing the mutation to their offspring, but the severity and age of onset can vary significantly even within the same family. The most commonly mutated genes in HCM encode sarcomere proteins, particularly beta-myosin heavy chain, MYH7, and myosin-binding protein C, MYBPC3, which are essential structural components of the cardiac contractile apparatus. These mutations lead to the characteristic pathologic features of HCM, including myocyte disarray and asymmetric left ventricular hypertrophy. The histologic hallmark of hypertrophic cardiomyopathy, HCM, is myocyte disarray, a distinctive pathologic finding characterized by disorganized myocardial architecture in which cardiac myocytes are arranged in chaotic, haphazard patterns, rather than the normal parallel alignment seen in healthy myocardium. This abnormal cellular arrangement results from the underlying sarcomere protein mutations and represents a fundamental structural abnormality that contributes to HCM's pathophysiology. Myocyte disarray disrupts the normal coordinated contraction of the ventricle and creates an arrhythmogenic substrate that increases the risk of ventricular tachycardia and sudden cardiac death, making it both a diagnostic feature on endomyocardial biopsy or autopsy and a key contributor to the clinical manifestations of the disease. The three major pathophysiologic consequences of hypertrophic cardiomyopathy, HCM, stem directly from the abnormal myocardial hypertrophy and create distinct clinical problems. First, dynamic left ventricular outflow tract, LVOT, obstruction occurs due to the combination of asymmetric septal hypertrophy and systolic anterior motion, SAM, of the mitral valve, which is pulled into the outflow tract during systole by the Venturi effect. This obstruction is dynamic because it worsens with decreased preload or afterload and improves with increased preload or afterload. Second, diastolic dysfunction results from the stiff, hypertrophied ventricle that has impaired relaxation and filling, leading to elevated left atrial pressures, dyspnea, and increased risk of atrial fibrillation, even though systolic function remains preserved or hyperdynamic. Third, myocardial ischemia develops from a supply-demand mismatch in which the hypertrophied myocardium has markedly increased oxygen demand, while oxygen supply is reduced due to compression of intramyocardial coronary vessels by the thick ventricular wall, resulting in chest pain and providing an arrhythmogenic substrate that can trigger ventricular arrhythmias and sudden cardiac death. Dynamic left ventricular outflow tract, LVOT, obstruction in hypertrophic cardiomyopathy results from the combined effects of asymmetric septal hypertrophy and systolic anterior motion, SAM, of the anterior mitral valve leaflet. The pathophysiology involves the hypertrophied interventricular septum narrowing the LVOT, which increases blood flow velocity through the narrowed region and creates a Venturi effect, a drop in pressure that pulls the anterior mitral leaflet anteriorly into the outflow tract during systole. This creates a dynamic, variable obstruction because the degree of narrowing changes based on loading conditions. When preload decreases or afterload decreases, there's less blood in the ventricle and lower systemic resistance, bringing the septum and mitral valve closer together and worsening the obstruction, whereas increased preload or afterload pushes them farther apart and reduces the obstruction. This unique hemodynamic behavior explains why HCM is the only cardiac murmur that paradoxically increases with maneuvers like Valsalva or standing that decrease venous return. The classic board examination vignette for hypertrophic cardiomyopathy, HCM, features a young athlete typically in their teens to 30s, presenting with exertional symptoms such as dyspnea, chest pain, or syncope, often accompanied by a significant family history of sudden cardiac death at a young age. The pathognomonic physical examination finding is a harsh systolic murmur heard best at the left lower sternal border that exhibits unique hemodynamic responses. The murmur increases in intensity with maneuvers that decrease preload, Valsalva strain phase. Standing, because reduced ventricular volume worsens the dynamic LVOT obstruction and conversely decreases with maneuvers that increase preload or afterload, squatting, leg raise, hand grip, because increased ventricular filling or systemic resistance reduces the obstruction. This distinctive response to bedside maneuvers, being the only cardiac murmur that gets louder with decreased preload, is the key diagnostic clue that differentiates HCM from other causes of systolic murmurs such as aortic stenosis or mitral regurgitation, making it a high-yield testable concept that requires recognition of both the clinical context and the characteristic hemodynamic behavior. The most common symptoms of hypertrophic cardiomyopathy occur in a characteristic order of frequency, each reflecting distinct pathophysiologic mechanisms of the disease. Dyspnea is the most prevalent symptom, affecting approximately 90% of patients, and results primarily from diastolic dysfunction caused by the stiff, hypertrophied ventricle that cannot relax and fill properly, leading to elevated left atrial pressures and pulmonary congestion. Chest pain is the second most common symptom, occurring in about 75% of patients, and develops from myocardial ischemia due to a supply-demand mismatch in which the hypertrophied myocardium has increased oxygen requirements, while coronary blood flow is compromised by compressed intramyocardial vessels. Syncope affects 15 to 25% of patients and typically results from either ventricular arrhythmias arising from the disorganized myocardial architecture or from severe LVOT obstruction that limits cardiac output, particularly during exertion when peripheral vasodilation cannot be matched by increased flow. Finally, palpitations are commonly reported and usually reflect underlying atrial fibrillation, which develops in 20 to 25% of patients due to chronic left atrial enlargement, or ventricular tachycardia, both of which carry significant clinical implications for stroke risk and sudden cardiac death, respectively. Hypertrophic cardiomyopathy, HCM, holds particular significance in the athletic population as it represents the leading cause of sudden cardiac death in young athletes under 35 years of age, a devastating outcome that can occur even in previously asymptomatic individuals during or immediately after athletic competition. The mechanism of sudden death in these cases typically involves ventricular arrhythmias, ventricular tachycardia, or ventricular fibrillation, triggered by the combination of exercise-induced hemodynamic stress, myocardial ischemia from supply-demand mismatch, and the arrhythmogenic substrate created by myocyte disarray and myocardial fibrosis. Due to this substantial risk, all athletes diagnosed with HCM, regardless of symptom status, genotype, or presence of outflow tract obstruction, receive a Class 1 recommendation for permanent restriction from competitive sports, a difficult but necessary intervention to prevent sudden cardiac death. This underscores the importance of pre-participation screening in young athletes and highlights why any young person presenting with exertional syncope, unexplained dyspnea, or a family history of early sudden death should be evaluated thoroughly with echocardiography and ECG to identify HCM before tragedy occurs. The physical examination findings in hypertrophic cardiomyopathy are distinctive and reflect the underlying pathophysiology of the disease. An S4 gallop is nearly universal in HCM patients and results from forceful atrial contraction against a stiff, non-compliant left ventricle during late diastole, creating an audible fourth heart sound that reflects the severe diastolic dysfunction characteristic of the disease. A bifid or double apical impulse is a pathognomonic finding on palpation that represents two distinct pulsations felt during systole, the first from the forceful atrial kick, corresponding to the S4, and the second from vigorous ventricular contraction, creating a characteristic tapping quality that can help distinguish HCM from other forms of left ventricular hypertrophy. The hallmark auscultatory finding is a harsh crescendo-decrescendo systolic ejection murmur heard best at the left lower sternal border, generated by turbulent flow across the dynamically obstructed left ventricular outflow tract, with the unique characteristic that it increases with maneuvers decreasing preload and decreases with maneuvers increasing preload or afterload. Finally, pulsus bispherians, a double-peaked arterial pulse best appreciated in the carotid artery, reflects the initial rapid ejection, followed by mid-systolic obstruction, and then a second peak, though this finding is less commonly detected and requires careful palpation technique to appreciate. The hypertrophic cardiomyopathy murmur exhibits a unique and pathognomonic response to the Valsalva maneuver, increasing in intensity during the strain phase, which makes it the only cardiac murmur that paradoxically becomes louder with decreased preload. The physiologic mechanism underlying this response involves a sequential chain of hemodynamic events. The Valsalva maneuver, forced expiration against a closed glottis, increases intrathoracic pressure, which impedes venous return to the heart and thereby decreases preload, resulting in less blood volume within the left ventricle. With reduced ventricular filling, the hypertrophied interventricular septum and the anterior mitral valve leaflet are brought into closer proximity during systole, worsening the dynamic left ventricular outflow tract obstruction, as the mitral leaflet is more easily pulled into the narrowed outflow tract by the Venturi effect. This increased obstruction creates more turbulent flow and a louder murmur, a response that stands in stark contrast to all other cardiac murmurs, such as aortic stenosis, mitral regurgitation, or ventricular septal defect, which either remain unchanged or decrease in intensity with Valsalva due to reduced cardiac output and flow across their respective lesions, making this bedside maneuver an invaluable diagnostic tool for distinguishing HCM from other causes of systolic murmurs on clinical examination. Squatting produces a characteristic decrease in the intensity of the hypertrophic cardiomyopathy murmur through simultaneous increases in both preload and afterload, making it a valuable bedside maneuver for confirming the diagnosis. When a person moves from standing to squatting, the compression of lower extremity veins and the shift in body position increase venous return to the heart, increased preload, while the isometric compression of leg muscles and positioning also increase systemic vascular resistance, increased afterload. These combined hemodynamic effects result in greater left ventricular filling with more blood volume in the chamber, which pushes the hypertrophied interventricular septum and the anterior mitral valve leaflet farther apart during systole, reducing the degree of left ventricular outflow tract obstruction, as the mitral leaflet is less likely to be pulled into the outflow tract by the Venturi effect. With less obstruction, there's reduced turbulent flow across the LVOT, producing a softer, less audible murmur, the exact opposite response to that seen with Valsalva or standing, which decrease preload and intensify the murmur. This predictable response to squatting helps clinicians distinguish HCM from fixed obstructive lesions like aortic stenosis, where the murmur intensity remains relatively unchanged with positional maneuvers since the valvular obstruction is not dynamic. The hypertrophic cardiomyopathy murmur responds predictably to various bedside maneuvers based on their effects on preload and afterload, with a consistent underlying principle. Anything that decreases preload or afterload worsens the dynamic LVOT obstruction and intensifies the murmur, while anything that increases preload or afterload reduces obstruction and softens the murmur. Standing causes venous pooling in the lower extremities, which decreases venous return and preload, resulting in less blood in the left ventricle and bringing the hypertrophied septum and mitral valve closer together, thereby worsening LVOT obstruction and increasing murmur intensity, similar to the Valsalva effect. Sustained hand grip exercise, isometric contraction, increases systemic vascular resistance and afterload without significantly changing preload, which elevates left ventricular pressure and creates a larger pressure gradient that keeps the septum and mitral valve farther apart, reducing obstruction and decreasing the murmur. Passive leg raise increases venous return by shifting blood from the lower extremities back to the central circulation, thereby increasing preload and left ventricular volume, which separates the septum from the mitral valve and reduces LVOT obstruction, making the murmur softer. Understanding these maneuver responses is clinically essential because they allow bedside differentiation of HCM from other systolic murmurs and demonstrate the unique dynamic nature of the outflow obstruction that defines this disease.